Welcome, everyone. On behalf of the Centers for Medicare and Medicaid Services, Division of Tribal Affairs, I would like to welcome everyone to an All Tribes webinar. My name is Nicole Pino, and I work for Kaufman and Associates. I'll be your moderator today. Today's webinar is titled Tribal Sponsorships Best Practices. Please note the webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. And next slide, please. And at this time, I will turn it over to Beverly Lofton.
Thank you, Nicole. Thank you so much. All right, so welcome to today's webinar. I'm Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs at CMS. This webinar is in collaboration with the CMS Division of Tribal Affairs and the National Indian Health Board, also known as NIHB. During the webinar, NIHB will provide an overview of the tribal sponsorship program and also discuss how tribes may elect to pay premiums on behalf of uninsured tribal members to purchase health insurance coverage through the health insurance marketplace. The presenters will also discuss best practices and lessons learned, including some examples of tribal sponsorship success stories. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website at go.cms.gov/AIAN. The website link will be added to the chat. So we are pleased to be joined on this webinar by Christian Visui from NIHB and our guest speaker, Selena Simmons from the Tuba City Regional Healthcare Corporation. So I am now going to turn the webinar over to Christian to begin today's presentation.
Yeah, thank you, Beverly. It's always an honor to be able to do a presentation for you guys on different topics that might be able to help you, do your outreach and education, and what other programs that are out there that might be able to help you get some of that revenue back into your facility. So, as Beverly said, this is a presentation on tribal sponsorship and the programs. And, as I do this work for Indian country, I hear different things when I visit facilities and also just doing presentations throughout the community. And some of these things that I always bring back to inform you of, what's going on as well, too. And this is one of the topics that always comes back to let us know that, hey, can we learn more about this, or can we hear from other maybe programs that are doing this, other tribes that are starting this program for their facilities as well, too. So hopefully you guys learned something from this presentation. So let's go ahead and go on to the next slide. So for tribal sponsorship health insurance program, the program itself is, it was under, I want to say it was the ACA of 2010. It provided an opportunity for tribes to establish a program to where they can purchase health insurance coverage for their uninsured tribal members. And so through this, trying to find out, how do we get our tribal citizens onto health insurance? And sometimes it's because they can't afford that Medicare premium, or they can't afford the premium through the marketplace, even though, it could be low for them. You think it's low, but when those that live in the tribal community, sometimes they're on a fixed income as well, too. So the tribal sponsorship, what it allowed for tribes to do was to be able to pay those premiums for American Indians and Alaska Natives. And each of the programs within the communities, they sometimes do things differently. And we always say that our tribal communities are very unique. So depending on what your community is in need for, or maybe it could be a different group that is uninsured. It could be your elders, or it could even be maybe a family that it can't afford the premium for the marketplace, but they do qualify for it. So depending on what that is, or maybe it could depend on how many of your tribal patients that are coming to your facility and they're getting referred out. It could be for a specific maybe disease that they're being referred out for. So it could be, different reasons of why a tribal sponsorship could be beneficial to each of the facilities. And the sponsorship increases their third-party billing revenue. And Selena's going to be able to share with us how they started their program. And it's interesting how it happens. And then we hear about how it's very beneficial and how it has brought in a lot of revenue back into the facility as well too. The investment is something that would fall on the facility and the staff there as well too. It's a lot of work, but when you see the positive returns that come back into the facility and what you can do with that amount of money that is being put back into maybe certain services as well too. Some tribes usually start from a small program, maybe like Medicare Part D is somewhere they'll start at, and then they'll do maybe only 20 patients or so, just so they can see how the program can start, which is what they call a pilot program. And through the sponsorship, you'll also be able to go into an agreement with the patient, and you'll kind of hear what Selena is doing on her end and how they decided to do this agreement with their patients as well too. So it's a very interesting program that really does bring back some good revenue back into the facility. So next slide, please. So why tribal sponsorship? As I had mentioned, it's a financial support for the tribal citizens that are in need of purchasing health insurance coverage. And the reason why tribes want to see if this is something that might work for them as well too. They're seeing maybe high cost patients being referred out, and their purchase referred care funding is going down because of that. There are some patients that have high cost medications as well too. The other thing is we have elders and those that are disabled that might not be able to pay for their premium for Medicare, and that's a possibility as well. And then patients that might be eligible for the marketplace plan. We always hear that the reason why our tribal citizens do not enroll into a marketplace plan, and it's because there's premiums attached to it. And so that could be a reason why you want to do a tribal sponsorship for your facility. And what are some of those benefits coming out of tribal sponsorship? Having that revenue coming back into your facility, that could bring back additional maybe equipment. You could hire staff as well too. And maybe there are programs that are currently in your facility that you want to expand. And there are some other, many other things that might be able to come back, like maybe bringing in a specialty provider as well too. And a lot of times when you look at tribal sponsorship, it also benefits the patient, because a lot of times maybe the patient does not want to leave their land as well too, to get seen when outside of their tribal community. And maybe there's a hesitation behind that. And so when the revenue comes back into your facility, you might be able to keep those specialty services within the facility as well too. You'll also be able to increase tribal citizens' access to healthcare and the health insurance. And so there's a lot of good benefits that come with this. I think one of the big things that I've always heard is that preserving that purchase referred care funds. It's one of those things where we want to hold on to those funds as long as we can, because you just never know what the future is going to hold. And maybe there's an individual that is, that's not eligible to get onto maybe the marketplace plan. There could be other reasons of the reason why an individual is not able to get coverage as well too. And if that's so, then that purchase referred care funds can be there for that individual. The other thing is that with outreach and education, we're always wanting to make sure that our uninsured patients, the rates for that are going down. We don't want our tribal citizens to be without health insurance. We want to make sure that they do have some sort of coverage. And so if you are able to pay those premiums that an individual just can't pay for, then you're decreasing the uninsured patients as well too. And we always talk about providing access to specialty care as well too. A lot of our patients feel like, well, I don't want to get sent to the collections, or I don't want to have to deal with medical bills. And so a lot of times they may not want to go outside of the IHS or tribal facility just for that reason as well too. So the benefits of tribal sponsorship is it does provide a better way for our tribal citizens to get those specialty care that that they may need that's outside of the IHS facility as well too. So here I want to provide an opportunity for Selena to be able to give us her perspective of how they started their tribal sponsorship program at Tuba City Regional Health Center. And Selena is she is the patient benefits coordination manager for Tuba City. And she has been working at Tuba City since 2008. And she started out as a patient benefits coordinator. So having that background really helped with being able to get this program started as well too. And she'll give you a perspective of being able to understand how it started from the very beginning as well too. And Tuba City is in a place that is extremely rural. So we're talking about, the nearest town being probably about maybe 2 hours away from her as well. And then, Phoenix, Albuquerque, probably even Utah. Those are the biggest cities that where, sometimes they may have to send out their patients as well too. And it's kind of interesting at Tuba City, they do have a cancer center there as well too. And just understanding that, how much it costs, the expenses of cancer patients, and understanding that perspective, made that decision for Tuba City as well too. So I am going to hand this over to Selena now. Go ahead, Selena.
Okay, good afternoon, everyone. All right, I'm Selena Simmons with Tuba City Regional. I'm the Patient Benefit Coordinator Manager, and I would like to kind of go over our process this afternoon with you and share some of our, a little bit of our process and how we're working with the sponsorship, which has really helped us a lot in our revenue. So, okay, we're here at Tuba City Regional. I'm going to start off with how we actually started. So this was a program that was started up back a while back. I would say back in 2014 when our CEO, which was Lynette Bonar back then, she kind of introduced that information to us, but we really didn't go into the planning process at that time. That's when the marketplace was coming up board. We're hearing about, getting prepared for this marketplace and everything else. So in 2015, Lynette went up to Alaska. She participated in a sponsorship program in Alaska. So she came back with this information and brought the information to us. And so she brought us together and she said, we need to go into this because this is what they're doing in Alaska, and I think we need to do this. So we gave it a shot. We started. So the end of November 2015. So our CEO says, okay, we need to go see Chickasaw in Oklahoma. So in 2015, there was me, a pharmacy tech, one person from finance, our CEO and CTO all went there. We met with the Chickasaw department and we had a discussion to how their plan was, how they started the process, the step-by-step process that they went into, and they were showing some of the revenue that it all entailed. And that was a good start, and it looked like a good process. So we started as we came back with that information here back to Tuba City Regional after we met with them. So when we started that, but the information that they shared with us, we started on our own on this side. With some of their information, we changed some of the information to fit our facility. So the process that we had to start with is creating a proposal with the cost and RX clients. So we had to present that, the cost of that. How many people are out there without the Part D? How many people are uninsured? The cost. We had to pull all that information together. Just to kind of start out with that, we had to filter through all the Medicare patients first. And so we had to work with a pharmacy group. So we kind of filtered all that. So we came up with 75 to start with. So, okay, let's start this. So we got the names, everything on the spreadsheet. So we got that already. And then we had to create brochures to fit our facility. And that was for the Medicare Part D. So we had to fit that to fit our facility information. And then we had to do more the enrollee job description, just a regular job description like a patient coordinator, but this had to fit the enrollee. The enrollee does the same thing as an patient benefit coordination or thing, but they're enrolling on the Part D. That is our major job to do. So we had to do the job description. And now we had to work on the MOUs and the MOU and the MOA, Memorandum of Understanding and Memorandum of Agreement with our legal aid to change the format to fit our facility. So he had to work on that. It took a while to get that done. So he finally got that all in place. CEO, everybody viewed it, and it was good to go. So we got that all. And then I had to work on a policy, the Part D policy. So I got that in place. It was reviewed by the whole facility. Okay, that looks good. So we got that to go. And then we had to do the credible coverage letter for Medicare. This is the one we use every year for, I think every facility on the reservation uses this coverage for that letter that goes out to the patient. So that's the letter we use, but we had to format that to fit our name in there. So we use that. And then create an expense for the enrollee, the person that's going to be doing the enrollment. All the expense and everything had to be set up. How much is it going to cost for the staff, their salary, their equipment, their setup, everything, going out on home visits and everything else. Who's going to be there? All that expense going to be. So we got that in place. And then we had to create our Medicare Part D process flow. How are we going to do this? What's the first step to the last step? So everything was put in place for a CEO and everything, everybody to view. These are going to be our steps. And then the final process was the legal review of all documents. Everything had to be finalized. So everything was finalized, and I said, okay, this is good to go. Okay, let's go. So once we got everything in place, everything was good to go. So so me and my Medicare Part D enrollee, her name is Sally Charlie. So we got together. Okay, so we're going to use this brochure that we got, and then we're going to use the IHS credible coverage letter on all these individual patients, of Medicare patients that do not have Medicare Part D, because we're going to screen every one of them and filter each one of them and find out which ones do not have Part D and who are at a very high cost and up into the thousands. So we had to make that selection. Then we went into the system and create a mail merge with these individuals. So we sent these out. So the clients finally got that back. They had signed, some elderlies do not exactly know where to sign. So they bring the letters back to Sally, and we got those MOUs signed. And then the CEO signs off on them too as well, and I sign off on them. Those go into their folder. That folder is created for them at that time. with a checklist that this has been received, this has been received, everything in a row, the step-by-step process. So we got that going. And then our Medicare Part D enrollee, she's very fluent in Navajo. She's very fluent, so word by word by word. She educates all the enrollees in Navajo to make them understand this is an agreement between you and I and the facility. This is how we're going to use a program. We cannot have you go off into another facility and use a program. This is between you and I and the facility for you to use that program here at Tuba City Regional and our site clinic in Lichi and one in Page. These are the areas you're going to be using to work with you for the Medicare Part D coverage. So she made them understand that, and then before they leave her office, they kind of repeat what she said back to her, so they understand. Excuse me. So they understand word by word what this program is about. And so she lets them know this is not out of your pocket. We're helping you to pay for the premium. This you're not going to be paying for this. We're helping you out because I know financially you're not able to afford this because that's one of the things we look at first. All patients are pre-screened for every other coverage first before they are even enrolled. They cannot have any other insurance coverage. So if we find that they do have other coverage, we're not able to assist, but help them assist with their either private insurance or they may have coverage. And so we help them out and understand that they need to provide their insurance every time they come to our facility. So we're not conflicting with the information on private insurance coverage. So we make sure and then we have to have an actual denial from access. We try to assist them with access and make sure they get a denial before we do enroll them. So we had to screen and pre-screen every one of them, make sure we're not having anything else that's gonna interrupt with their service here with the program. So then from there, once that's all cleared and done with, once they're cleared that they're eligible for the program, she will proceed with the enrollment using the Medicare.gov link. So once we do that, and then picking out the script at the time, which most of our patient benefit coordinators during open enrollment or any time, they actually have to have the listing of meds. Here with the Part D that we're using, the current one we're using is SilverScript with a gap coverage. So when we're enrolling into that program, we skip over that process of not entering the skip. We skip right over the script. So that allows us to put in the choice that we want for that individual. So she continues with the enrollment. So once that is, so that in order for us to allow out of an enrollment period, we enroll them into the loss of coverage. That's what we select that will allow us to enroll at any time. So that's one of the options that we pick. So once that enrollment is processed, our return address on the application will be to Tuba City Regional. It'll be to me. It will have my name on it at the end. It'll say to Selena Simmons, and it'll have the patient's information on there too. So when the mail comes back, it's coming back to us. That's where we are viewing everything. We're tracking the mail, we're tracking the EOBs, everything that we're tracking the payments and date of enrollment and renewal time. So when we are enrolling, when the invoice is received after the enrollment starts, the premium is paid on a yearly basis, not on a monthly. So we know, like if you say we enroll them today, it will be the next invoice. We will the new enrollment period be we counted up to December. So if we enroll now, it be the payment from here to December, and then we restart the MOU again, and then another payment be from the next year. So that's how we do that. So we're tracking every one of them. If we are to put the patient's name on the mail, we will lose the contact with that patient. And there's a lot of times that has happened in between. The representative contacts a patient. Somewhere we're missing the invoice. So that's where we encounter those issues. So the Part D sponsorship, Medicare Part D, we went live in 2018 and it is still going. We are growing every day. We're growing every day. We're accumulating maybe 3 or 4 or 5 every day. Because these referrals are coming from pharmacy, oncology, infusion, referrals from providers and pharmacy. Patients are, it's grown. It's adding to our list every day. So the total that we have enrolled from since 2018 to 2024, we have 746 enrolled. So like I said, it's increasing every day. The total revenue would be on the next slide. So anyway, so we have 746 patients on limited income and not able to afford Part D coverage. Those are the individuals that we are looking at and have a high pharmacy cost. And so, and then plus oncology. Oncology is very expensive. Infusion is in the 26,000 per service. So those are expensive, expensive meds. So we're really working with pharmacy on these individuals. So, and then, like I said, all the patients are pre-screened for alternate resource before we go forth with the sponsorship program. Here on the Medicare Part D enrollee, our yearly totals, as you can see right now, on the very top is 2018 to 2019. The total premium we paid at that year is right there, 115,000. Total build up, 1,989,282 that was billed out that year. Out of pocket is something that your insurance will not cover. That's like it's your share of the cost. That's what you owe to the insurance. So that's out of pocket right there. And the return revenue $1,357,469.70. So that's a total revenue for the first year. We enrolled 302. That was a really good first year. It really got these individuals going. So that was our first year. And the second year, the same thing all the way across up to 2023. We have grown at the very bottom, shaded in gray, very bottom, we're at the 9 million right now. So that's our revenue. So if we didn't have this going, this would be lost revenue. We would not be collecting this. This is what we would be losing in revenue if we didn't have that. So right now, our revenue is still growing. That 2024, I'm still calculating on a different spreadsheet. So once the end of the year, I will be adding that to the totals. So that's how our totals look. And I present these totals to the board members and our SLC group CEO and the pharmacy. This is what we're collecting. And they're very happy to see this, our numbers. There were some challenges that we faced during this when we first started. Patients were changing their address from Tuba City mailing address to their own, which created a loss of contact. I'm not exactly sure how this was happening. Either the patients themselves were contacting them, or either the SilverScript or the other plans we were using may have contacted them for a certain reason. I'm not sure what happened, but addresses were being changed. And so the patient would get the bill and said, and they would say, I thought you guys were paying our bill. I got this mail. I got this. So that's where they were bringing them in, and we had to make those changes for them and call the plan, let them know that the address needs to stay as is under Tuba City region, because we are tracking the payments, the invoices, and everything else goes back to us. So we're tracking everything. And then the Part D plan not recognizing the IHS credible coverage letter remailing. Sometimes they do not recognize, and they're charging them for the late enrollment period. So their premium is going to be higher. So we had to resend the coverage letter and let them know that the IHS 638, we are the credible coverage. We're covering them up to this point now. Now that they're on this Part D plan, this is just to let you know we have coverage here. So then we have to remail that to them, to the Part D plan, and let them know. So that way they bring the payment back down. And then mail crossing over. So let's say we sent the invoice to finance. Finance sends the payment out to SilverScript, the plan we're working with. By the time they get it, it's gone beyond the date, so the mail is crossing over, which kind of a loss in coverage when they're looking at it. They will say, we lost a payment, we did not receive the payment, so we have to go back and pull our spreadsheet with finance and let them know, no, we did send a payment, so we have to let them know. So we're working with Blue Cross, not Blue Cross, we're working with the Medicare Part D representatives and share the information with them and let them know they need to be reinstated. So we're working with them to make, sometimes it's kind of hard sometimes when we change the plan to a different plan and then we have to start all over with that. So finally somewhere down the road everything just falls in place. So it's kind of like you have to really track everything. So that's one of the things that you have to really watch out for, just to make sure you don't lose that coverage on your patients. We have to make sure we keep that going, because a lot of the billing when they come in for services, when they come to pick up their meds, make sure they have coverage and this is ongoing. So registration will always be in contact with us. Can you check Part D coverage? Because we're using the MBI system for Medicare. I check the eligibility and let them know that they still have coverage. So we keep checking that. And then the thing too is right now we have patients that are on traditional Medicare. That's the Part D we're working with. We have representatives that come in and I don't know where it's happening. They're changing their plans over to HMO or PPO plans, Advantage plan. And we come back and then we get a notice saying that the patient has changed their coverage. And then we have to look at it. I check the MBI for the eligibility. And sure enough, their plan has changed to an Advantage plan. And now we have to get back with the patient, let them know why, kind of educating them why they need to be on a traditional Medicare. I know we're not really credentialed with HMO PPO plans here at Tuba City Regional. We're not set up with them. So we have to educate them. You have to stay on this plan. If you change it and wish to be on this other plan, we have to take you off the sponsorship program because you're making that choice. But some of them realize that when they do, they're responsible for the premium. So when that happens, they come back to us and then we're re-enrolling them. So that kind of makes it going back and forth. And it does affect finance. Rechecking coverage and counts and MOEs is recouping the payments. So we're going back and forth on this. So that's kind of a little bit of, things that we encounter every day. It's not, not every day, every now and then. So we have to really make sure we keep our patients educated on these plans, how they work, because HMO PPO plans are capitated plans that are assigned to a provider. PCPs assigned to them within that plan. I don't know if they're educated. They're educated on those plans when they enroll. I'm not sure how that's happening. So they kind of just bump all over and utilize different services, and then they end up with a payment. And then they bring in a bill to us and say they got billed for service because they changed their plan. So that's one of the things that we're really, really making sure they understand that they're under our MOU, the agreement that they had signed. So it's an everyday filing. My Medicare Part D enrollee is daily filing a sorting of mail from the EOBs that come in, and every other month we get a stack of EOBs, and it takes her a week to open all those letters and then put them in there and put in all the EOBs in order, the accounts on the spreadsheet, that the money that we've gained, all that stuff on the spreadsheet, and then she'll send it over to me. And then I add it to my side here to show you on the totals that showed that. So that's what it was. So, okay. So that's how that was. That's how we do. The Medicare Part D enrollee has her hands full, but we have a Medicare Part D enrollee. She is helping my filing clerk with all this work because it's really time consuming. Sometimes she's here after hours trying to sort out that mail. So it's very time consuming. So, and then now to the tribal sponsorship for the marketplace. This is almost the same process as it is with the Medicare Part D. The same process almost. Everything, the MOUs almost similar, but this one relates to the marketplace. So we went live in 2021. We started the oncology, the cancer center. I would say before we started the marketplace on that one, I say about a year after the cancer center was set up, we started noticing that all these total charges, patients being transferred out to other facilities with the high cost. We had one that was over in the millions, and PRC brought that over. Can we enroll this person? She's being referred out to different facilities, Flagstaff, but the billing is very high. She does not qualify for access. She has no other insurance. She's not, Medicare eligible. We go through all this stuff, every avenue, search every avenue. She didn't qualify for this, so that's where we started. Like, okay, we're going to do the marketplace too, besides the Medicare Part D. So we start doing the marketplace, and once we got that going, from 2021 to 2024, we had 62. I added on about 5 more just recently, so the number's a little higher. So it increases every day. We're getting these enrollees are being sent to us from providers, oncology, PRC referrals, high pharmacy costs. The same thing as a Part D. These individuals have a high cost in the marketplace. So we start enrolling them. So we gave it a trial. Okay, let's see how this works. We had to go through all the MOUs, a whole setup just like in a Medicare Part D, all the enrollment process, MOUs, the policy, the enrollee, their job description, everything that we named from the Medicare Part D, everything we followed the same process, and the legal steps and reviewed everything. Everything was good to go. So once we got that first one, we encountered one thing because Medicare, the marketplace Blue Cross Blue Shield was an HMO plan. A provider that was assigned was out of network. So we weren't getting our services paid for. Okay, we need to work on our provider to be assigned to the HMO plan for Tuba City Regional. That was another process. So I had to work with Alan Jersevic in Phoenix. He's with the grant and the Arizona Alliance. He was working out. Alan, I need your help with this. How can we? Because this is an HMO plan. We're out here in Coconino County. We don't accept this plan. How can you help us with this Blue Cross Blue Shield? We need to have the provider with oncology, the specialty doctors assigned to this plan. Who can I talk to? Who can you set me up with? We need to work this out. So he set me up with Blue Cross Blue Shield, the person to contact, a representative. That's where we all started. We got some of these providers enrolled with them. Finally, our service was starting to be paid for. I know we use a plan that's the bronze plan. That's the one our CEO says instructed us to use a bronze plan because the bronze plan is at a high deductible, low premium. But still, the high deductible is easily met. Maybe 2 or 3 ER visits. They call it crash and burn sometimes just to meet those deductibles. So we're using that plan. They meet that easily, and the insurance will start paying that. So we have gained a lot of revenue with that. So if we didn't have that marketplace with any of this with these patients that that don't have Medicare, that are eligible for private insurance through the marketplace, we would not have any revenue coming in. This is one of the things that we screen every patient. We screen everyone just like the Part D, make sure they have no other insurance, no type of coverage. They cannot qualify for access as well. So we have to screen every one of them, make sure. And so right now, I know recently I learned that the marketplace, even though they're denied for access, we have to wait 90 days for another renewal to make sure, because I think the reason why is a fraud that was going on. So that's the reason why we have to wait another 90 days and rescreen and make sure they're still not eligible for access. And then from there, we can enroll them into the marketplace. So we started out with 34 high-cost individuals, the 26 who is specialty care, oncology patients. Those are the ones they're coming from all over off the reservation. We're not only concentrating on Tuba City patients here on the marketplace. We're covering from down from Shiprock. We're coming from up on Kayenta, our surrounding areas. These individuals are using our cancer center because we're, I think, the third IHS facility, maybe I don't recall who was that we do now have a specialty care with cancer center. The only thing that we don't do is radiation. I think they're talking about that, having those services here. And so I'm sure if it will be announced that we can, that way it keeps our patients here. We're not sending them out. So like I said, the affordable care marketplaces for high medical costs, like oncology, infusion, PRC referrals. Now with the PRC referrals, I know there are some patients that do not have Part B coverage. You know, Access is going to deny a coverage if they do not have Part B. They will deny. They'll say they have other coverage. So we're looking at Part B coverage now. We're talking about it and doing the same thing for helping assist needy persons with the Part B coverage. So we're gonna try and see what we can with that. So we're still talking about that. We'll get that in place. Sometime it's still in the talks. So it's the same process of Part D set up and the premiums for each individual with the bronze plan varies from zero to at the most is $1,000. That's where it varies right now. That's where we've got everybody on that. So we can't think that, oh, the marketplace is too expensive. We don't know that because it's all based on their income, their yearly income. So we have to have the exact income information in order to insure these individuals. So that way at the end of the year, when they're filing their taxes, they're not paying back because you have a premium tax credit was based on this income. For your income, not that you're filing for taxes is different. You're higher, so some of them are being asked to pay back this much. So we're making sure their income is accurate. So like I said, marketplace is the same thing as a party. We're screening every one of them. So these are our yearly marketplace. We start back in 2021, even though we went live in 2021. And we might have missed a little bit off of 2021 where the EOB started coming. Me and Sally were going back and forth. Okay, what are we supposed? How are we going to be tracking this? Is the finance picking up on how are we going to know this? What's being paid out? What's coming in? We didn't know that, and then finally we were looking at the EOB. Okay, let's do it this way. That's how we were tracking off of the EOB. So right now, we are at this point where at the total revenue, 776,000 we're sitting up to last year. This year, I'm still totally everything. Yet those are not in place. I get the EOBs every day. Some of these EOBs go back to 2021 and 2022. So I'm shuffling, going back on those years, entering the information. So these are not exact counts. It's still, the numbers are still changing every day. So if you see to the far left, it says other facility in gray, $558,689.06. That is money that is like a person gets transferred elsewhere off our facility on a marketplace. This is revenue saved on the PRC side. This is not something that we're losing. We're helping PRC with this, so they're not using that money out of their bucket. So that's how our money looks. I calculate these every day, so I'm still working on everything from 21 to 2024. So I'm still entering those numbers. So that's how our numbers look. So the same challenges, pages, like I said, they changed their address too. Lots of contact, the same thing as we did with the Medicare Part D. A mail crossing over, invoices or lost. They say it was sent, but it's not received. So our mail is going back and forth just like the Part D. But we have a third-party payer that's going to be in place as of tomorrow. we're going to have a meeting with them. So we're sharing that spreadsheet so they'll be tracking everything for us and make sure we do not lose coverage. And then the daily filing, EOB's Blue Cross Blue Shield are coming in every day, and she's conducting interviews, a new enrollment. Their enrollees are coming over. I send those over to her. Once everything is denied, I send it over to Medicare Part D enrollee. Okay, look at this individual, get them set up for enrollment. So she's doing that. So but right now we're doing a lot of that. So patients are disenrolling without notice. Sometimes they voluntarily disenroll. Why? I really don't know. So we had to discontinue their sponsorship program when this happens. And we had to recoup the money when that happens. So sometimes they don't want to be a part of that anymore because I don't know what the reasons are. They would not say. But not too many. We only had 2 actually that disenrolled themselves. So that's their choice. We're not twisting their arm. It's their choice, but we're trying to help out. And then we have outside referrals of Blue Cross Blue Shield. The provider has to send that referral to Blue Cross Blue Shield to authorize that. So the doctors are aware of that. And a third-party pair that's being implemented tomorrow. We did a run as of over the weekend, and clients are enrolling every day, 1 to 2 enrollees every day, and then sponsorship gain and everything, the sponsorship between the two, the Part D and the marketplace. We're increasing our revenue so we can build more services on the reservation. That way, we're keeping our patients here on the reservation instead of sending them out. So that's what we're focusing on. And less PRC funds utilized, and then people don't have to travel to it that far. So we're really growing. So, and then true story, like we had a patient that had that is a cancer patient that was in dire need of services, and her services at the reservation were quite high. It was a priority. So we got her enrolled, and she is being taken care of now. Her services are being paid for. Everything is good for her, and she's glad she has coverage. So she's going back between here in Flagstaff and Phoenix. Her services are covered. So that's a saving for PRC. And there's another one too. He had needs for his supplies too. There's another one. Their supplies they're expensive on like an infusion supplies, infusion meds, all this stuff. It involves with every patient that we're enrolling. All have stories to them. They have their medical is a priority. We do not want to turn these patients away. We're taking care of their patients by having these medical insurance. So it's really a save to us. So we're really helping these individuals. So like I said, all sponsors have serious health issues where sponsorship has really helped with costs and helping these individuals. Some are very glad that we're able to help them. And so we're doing it the best we can to keep them enrolled, and we will keep the sponsorship going as long as we can. And thank you. I move on. Turn back over to Kristen.
I love hearing these stories of, other ways that we can be able to bring revenue into the facility for those patients that may not want to leave the reservation as well too, or prefer that, they try to hold on to the amount of money they have at hand, and they just can't afford to be able to pay those premiums. And so to have a tribal sponsorship available to them is something that is very beneficial to our tribal citizens as well too. So this is just our contact information here for myself and Selena. And I'm going to go ahead and turn this over to Beverly so we can start the Q&As.
Thank you so much. What I'll do now is just hand it to, is it Nicole? Nicole, yes, I'll hand it to Nicole so that we can check to see if anyone has any questions, and Nicole can go over instructions.
Perfect. Yeah. So this is our time for questions. So we'll be first addressing the questions already submitted in the Q&A box.
Hi, everybody. My name is Cindy Lamesh. I'm Acting Technical Director for Tribal Issues in CMS. Probably this is for Chris. So, Kristen, in an ideal world where tribes don't have the administrative infrastructure that Tuba City does, and this is really impressive what they do, and I don't know whether this would take a statutory change, but is there a way where the tribe, the administrative staff could do this online through healthcare.gov or through the Social Security Administration just to streamline this process because this just seems like it would be a very heavy lift for a tribe that lacks the staff. And it's so important, but just looking ahead, is there a better way?
I mean, some of the processes probably could be streamlined a lot easier, and rather than having to go through certain hoops like, making sure that the address is correct and it doesn't get changed mistakenly when a patient calls in to either, to talk about their Medicare benefits, or maybe even just a health insurance marketplace as well too. Both of them are different. And yes, there are different things that have to happen on both sides. But I think that the tribes would also like to have that say in what needs to happen on their end as well too. But having someone on the marketplace side, or having someone within the Social Security, the Medicare side of it, is very beneficial to have someone with the knowledge of Indian health. And it's a lot different, not for someone that may not have that knowledge. And when someone calls in, as a tribal member calls in and, is having difficulties or challenges, and it's always good to make sure that there is someone on the other end that really understands the Indian health system and how that works for them as well. Good question. Oh, Nicole.
Yep. Thank you, Cindy. That was a great question. And Kara, I do see that we have one more participant with their hand raised. Rosa, would you be able to unmute her?
Can you hear me?
Yes, we can hear you.
Oh, great. Thank you for the opportunity, and it is great information. Hi, Kristen. It's me, Rosa, from Paskayaki Tribe. So I'm sorry because I missed some of this. I was running from another meeting, but I think that the challenge for a lot of us in Indian country is who pays for this, and how do we help that member, because in order for them to, a lot of them don't want to take the marketplace because of the cost, or they don't understand that they get the premium credits and how the tribe has to get all that financial information to make sure that they're not going to end up having to pay more at the end of the year. A lot of members think, well, why can't the tribe pay for it? So that's a little bit of the challenge that I seem to have in understanding a lot. Most recently, we also noticed that a lot of our members that were applying for access, as it is mandated for a lot of Indian country, as an alternate resource to be in PRC or whatever other programs, they were being turned over to the marketplace without their knowledge. And then to get them off, because, marketplace is considered an alternate resource, to get them off, it was like pulling teeth. So I know there's a lot of fraud going on. And so, I've experienced at least 5 of my members that have an insurance that were put on the marketplace without their knowledge, and then to get them off was, ridiculous. But that's another challenge that we're seeing right now with the fraud that's been going on. Even members that are currently on Access Medicaid, they're being sent to the marketplace and starting up a marketplace. So how does that happen? And, do we have connections or contacts at the marketplace that do know and understand Native American health insurance?
Okay, so that was a lot right there. That could be like a whole hour of conversation here. But thank you so much for sharing all of that. And there are some individuals at the marketplace that are hired specifically to answer questions on, specifically for American Indians and Alaska Natives. And I know that from the very beginning, we've had a lot of challenges with the marketplace. on being able to get individuals to answer, some of those questions related to some of those different unique situations when it comes to American Indians and Alaska Natives. Of course, their facility that they rely on is either IHS tribal or maybe sometimes even the urban programs as well too. So it's one of those hit and miss kind of things. And I've called Marketplace on several occasions for individuals that have contacted me. And it's a lot about understanding what you're asking as well. And a lot of our tribal citizens might not be able to communicate that to the individual and ask a question that the individual on the other side is able to understand as well too. And that's some of those challenges that we want to hear about. I want to understand exactly what those are. Specific examples are very good for us to be able to relay back to SOCIO and get that information out there for them of what they need to do to be able to help our tribal citizens that are calling in on their own as well too. And as far as the other portion of your question about tribal sponsorship of who is able to pay for that, I'm going to have Selena come back on and answer that portion.
Hi, Rosa. Hi, this is Selena. So when we first started, it was allocated out of our funding, patient benefit coordination, for a couple years. You know how we do the fiscal year every year. So there was a budget for that. So finally our CEO and our quality director, he's no longer here, but we started, and he said, okay, we're gonna take this budget out of that PRC allocated funding. So that's where we've been using that funding. So now we're talking about putting whatever we pay out as a premium, that money we're going to put back into the PRC bucket. That's what we're talking about right now. So we're replacing that money that comes back in as a return, a revenue. Okay. So we're going to put that back for their use. So that's how we're using that PRC funding to assist with the premium payment. That's how we're doing that. And you have to really educate these patients because they think that they're going to hear, oh, it's going to come out of my pocket. No, it doesn't. You're not paying for that. We're assisting you with the payment. You have to really know, have them understand. When you're doing the marketplace, you cannot enroll a patient into a marketplace on our side. They had to be CAC enrolled and certified or navigator. You have to have a consent form. We have a consent form for every patient that we enroll, and we have MOUs in place for every time we are going to enroll somebody. They have to sign it. I'm in agreement. I have to sign it. The CEO signs that. That's how we're working this program to avoid the fraud.
But okay, so I understand the payment process. Does a tribe pay that directly to Marketplace, or they invoice the tribe? How does that process work? And okay, maybe I can call you at a later time. And I really appreciate you, Miss Selena, for all the information sharing.
Yeah. That we do not. When the invoice comes in, we send it to finance. Finance will cut the check and send it to the plan that we're working with. That's how it goes.
Okay. Yeah, I thought maybe and I know you talked a little bit about Part B, and my understanding for Part B is, and some tribes are assisting some members, but I for a long time was under the impression that under Part B, the member has to pay it, and then the tribe would just have to reimburse the member. But that's, again, very difficult because a lot of our members would not bring in those invoices or statements of the Part B. Are you working around that?
We're starting that. We have not actually started with the part B yet. The part D we're doing, that comes to West under Tuba City Regional, to our mailing address. That's how it's set up online. We do the online enrollment. We put Tuba City's address in there, so the part D invoice is sent to us. So, and then the same thing with the marketplace. Our mailing address is put on the invoice.
Okay.
Yeah.
Alrighty. I might be able to reach out to you, Ms. Selena, at a later time, and I really appreciate everyone's time. Thank you, everybody.
You're welcome. I know we have another Utah Navajo is reaching out to us. I think they want to join this program. So they reached out to us. So we're going to get with them sometime to show them how to do the program.
And that'd be wonderful. If would you consider inviting the Paskayaki tribe PRC program to that training or wonderful. I appreciate you.
You're welcome.
Thank you, Rosa, and thank you, Selena. But I think the bottom line of understanding tribal sponsorship is that, it increases the third-party revenue significantly. And I think most of the tribes that have done this so far has realized that it surpassed all of their tribal expectation. And I know that there are some questions that are in the chat as well. So we'll go ahead and send those out later on. But I'm going to go ahead and send this back to Nicole.
Okay, yeah, thank you. Those are great questions, and I know I want to be mindful of everyone and their time for today. So I will just go ahead and read one comment and then pass it over to Beverly for closing. We did have Cindy say that this is an incredible presentation, an example of both the challenges and huge successes of tribal sponsorship. So thank you to NAHIB and Selena for sharing with us today. And I will pass it over to Beverly to help close us out today.
Wonderful, wonderful. Thank you, everyone. Thank you so much, Christian and Selena. You did a wonderful job. As you can see, you had wonderful comments and feedback. So I'm sure everyone else is feeling the same way. You can look here and see that you have Chris's contact information, and Selena's is on here now. So you want to take a quick screenshot so that you can contact if you were not able to get your question answered, or if you want to have a little more contact or dialogue with the two. So again, I would like to thank everyone for their participation in this webinar, and would just like to remind you that you'll be able to get information or material from the presentation from our Spotlight page, and that can be found under the American Indian Alaska Native Outreach and Education website. That is at go.cms.gov/AIAN under all tribes calls. And as always, you can submit any other inquiries to the Division of Tribal Affairs mailbox. Our mailbox is at tribalaffairs@cms.hhs.gov. So thank you, everyone, and have a great afternoon.